So we all know that patients with the heart failure, reduction in eGFR is the most common comorbidity, and we know that it is a cardiorenal syndrome. There is a bidirectional talk between heart and the kidney, and any insult, whether it is acute or chronic, by ischemia, infection, toxins, will stimulate neurohormonal activations in the form of RAS stimulation and sympathetic nervous system stimulation. And this results in crosstalk between heart and the kidney, and it ultimately affects both the organs. When kidney is involved in a patient with the heart failure, it is further aggravate the heart failure by virtue of anemia, volume overload, electrolyte disturbances, and metabolic abnormality. And often, these conditions are associated with diabetes and hypertension, which further aggravate the cardiorenal syndrome. If you look at the prevalence of cardiorenal syndrome, 30% of the patients of heart failure develop the CKD, and 66% of the heart failure patient has a eGFR less than 60, meaning stage 3 and above CKD is very commonly been observed in a patients with the cardiorenal syndrome. On the other part, renocardial syndrome, meaning that renal failure resulting in the heart failure is around 20% across the spectrum of the eGFR. And when patients enter into the end-stage renal disease, the prevalence of the heart failure is nearly around 40%. So this cardiorenal syndrome not only impose the prognosis, but it is also a big hurdle in starting and escalating the various group of the drugs. If you look at the overall prognosis of a cardiorenal syndrome, they carry very high mortality, almost 4 times higher than the patient who do not have. And when one of the component of the cardiorenal syndrome is present, it is almost 2 times higher than the patients without cardiorenal syndrome. We know all these things, so I am not going to go into the details of how we define the CKD stage 1 to 5. It is a progressive disorder. As the eGFR reduces, the stages of the CKD changes. The cardiorenal syndrome is also type 1 to 5. When heart involves the kidney, we know it is a cardiorenal. When kidney involves the heart, we know it is a renocardial. And when systemic conditions like hypertension, diabetes, infections, we know it is a secondary cardiorenal syndrome type 5. Before going into the details of the treatment, let me take you to the pathophysiology of the renal failure in a patients with the CKD. It is a multifactorial, but one of the most important aspect of renal involvement is by systemic hemodynamic and local intraglomerular hemodynamic. Systemic hemodynamic means mean systolic arterial pressure, means venous congestion, mean venous pressure, and intra-arterial means it is efferent and the efferent arterial. If you look the typical patients of congestive heart failure, the mean pressure reduces, central venous pressure increases, perfusion pressure reduces, and this is most commonly associated with the reduction in eGFR. If you look at the different efferent and efferent arterioles, whether it is dilated, constriction, or in combination, these also results in a renal failure. And if I show you that efferent constriction and efferent dilatation, this results in decrease in the eGFR, and this is the most common mechanism observed in a patients with the congestive heart failure. Now let us discuss who are the efferent and efferent constrictor and the dilators. The efferent constrictors are SGLT2, loop diuretics. It is because of NSAID. The efferent dilators are prostaglandins, ANP, and ARNI. The efferent constrictors are angiotensin II, norepinephrine. The efferent dilators are ACE, ARBs, and the ARNI. And this will help us in understanding how these drugs will protect the kidney function. We all know that pharmacological treatment divided into the two parts. One is the symptomatic improvements with the diuretic, digoxin, vasodilator, and then there is a disease modifying. We call it is a fundamental 4, or now we can consider it fundamental 5. We all know that fundamental 4 pillars, and I am going to restrict my talk today on ACE, ARBs, ARNI, and SGLT2. The ACE inhibitor is a cornerstone of the therapy for the heart failure for more than 3 decades. And if you look at the data of utilizing ACE inhibitor in a patients with the CKD, almost only 25% of the patients are receiving ACE inhibitor in a patients with the CKD. What was the issue with the ACE inhibitor? If you look at this diagram, the patients putting on the ACE inhibitor has efferent dilators, and as I mentioned, efferent dilators will deteriorate the GFR, and when you start the treatment with the ACE inhibitor, there is a worsening of the renal failure. But clinically patient was improving, and we considered this as a pseudo worsening. When the patient is crossing from the worsening renal failure to the AKI stage, reduction in urine output, reduction in increase in the serum creatinine level, and they are reaching on the top, the red part, they are associated with the increase in the mortality. And if you look at the pool data with the various ACE and ARBs used in a patients with the CKD, they increases the cardiovascular mortality by 19%. So we need some RAS blocker which has cardioprotective and nephroprotective effects, and then comes the ARNI, combination of sacubitril valsartan, by virtue of blocking the neprilysin and angiotensin 2 receptor. It results in simultaneous dilatations, nitriuresis, and diuresis, and hence it is helpful in a patients with the cardiorenal syndrome. It has been well established by Paradigm HF trial, where the patients with the ejection fraction less than 40% with the eGFR of more than 30, they are being shown beneficial in a patients with the heart failure. Let us see the data with the CKD. This is the pooled data of a ARNI in a patients with the CKD. Clearly shows it favors the sacubitril valsartan as compared to the acute competitor, that is ACE inhibitor, and reduction is nearly in the tune of 30%. If you look at the reduction in eGFR, it is 10 versus 7 in favor of sacubitril valsartan. If you look at the result in end-stage renal disease, irrespective of whether patient has a eGFR of more than 60 or less than 60, it is nearly around 30%. And most importantly, there is a 11% reduction in acute kidney injury when patient is hospitalized for the heart failure. So clearly, it proves the safety in a patients with the CKD as compared to the ACE inhibitor. The safety part in a terms of discontinuation due to the any renal dysfunction or hyperkalemia, it is nearly around 50% less as compared to the enalapril. And what's the clinical outcome in these CRF patients? It is same 21% relative risk reduction of hospitalization and cardiovascular death, which is at par with the Paradigm HF trial. Now, in the real world, there are few data come from the Asian subcontinent which looked at the patients with the CKD stage 4 and 5, because we all know these are the most difficult and the high risk subset. And what they have done is they have found out the clinical endpoint of CV death and hospitalization of the heart failure stage 1, 2, 3 in one group and stage 4 and 5 in another group. And if you look at the reduction of the primary composite endpoint, which is 28 versus 14, so high risk patients appear to be more beneficial with sacubitril valsartan. The similar study in a patients with the end-stage renal disease on a dialysis, maintenance dialysis, either peritoneal or a hemodialysis were studied, and they found there is an improvement in the systolic function at the end of 1 year, as also in comparison with the conventional treatment of ACE or ARBs, improvement in the diastolic function as well. We always look for the safety of this data, and they look at the safety data, and we are concerned for the hypotension during the dialysis patients. If you look at the data with the conventional treatment versus sacubitril valsartan, which is statistically insignificant. So hypotension, hyperkalemia, cough, angioneuritic edema, hospitalization because of cardiovascular diseases and all-cause hospitalization, which is statistically insignificant, proven the safety of this particular molecule in this study. But we need further large prospectus randomized control trial in stage 4 and 5 CKD to prove the hypothesis of sacubitril valsartan working better as compared to the ACE inhibitor. Based on this data, ACC expert consensus has released up to the eGFR of 30, you don't need to alter the dose. When eGFR is less than 30, one need to reduce the ARNI dose to half. If I look at the SGLT2 and CKD, I will not go into the details, just show the hemodynamics data. The diabetes is afferent dilators and SGLT2 is afferent constrictor. CKD patients are involved in DAPA-HF and EMPA-HF trial up to the eGFR of 25 and 30. Clearly shown that primary endpoints are reduces, hospitalization of the heart failure reduces, and EMPA was empowered to look at the eGFR. The eGFR reduction is 4.2 versus 0.9 in a favor of empagliflozin. Both the molecule has a CKD trial also, the DAPA CKD and EMPA CKD trial. The eGFR up to 25 and up to the 20 has been seen. And if you look at the primary composite of renal and all cardiovascular mortality, which statistically significantly reduced in both the groups. Interestingly, change in the eGFR is also in favor of SGLT2 receptors. If you look at the reduction in eGFR is 0.93 versus 0.76 in a favor of SGLT2 over a period of 3 years. And if you look at the data, subgroup analysis, whether patient was diabetic, patient has a eGFR of less than 45 or more than 45, and most importantly, urine albumin creatinine ratio higher or lower, the outcome is similar, clearly suggests there is a definite improvement in the patients with the CKD. If I want to summarize the whole management in my last 2 slides, up to the eGFR of 30, we are quite okay. One can start low dose and escalate based on the cardiac and laboratory parameters to the highest tolerated dose. When the patient reaches to the eGFR of less than 30, the role of beta blockers, SGLT2 and very low dose of ACE inhibitor, ARNI and MRA is out, and less than 15, only beta blockers and very low dose of ACE inhibitor. If you look at the evidence-based medicine, the composite of CV death, hospitalization of the heart failure or all-cause mortality, the patients of cardiorenal syndrome is standing on a step ladder from stage 1 to 5 up to the stage 3. All the 4 major pillars reduces the all-cause mortality and composite of CV death and hospitalizations. Stage 4, still ACE inhibitor, SGLT2, vericiguat, digoxin, and this myosin, cardiac myosin activator has its role in preventing the CV death and hospitalization. But when you look at the stage 5, even there are no moderate evidence also, the evidence are too weak. So further study should be directed to stage 4 and 5 CKD patient in heart failure to find out which drugs works better. Thank you for your patience listening.